chance of them dying in the 1 year, and if they required ICU admission, the chance of death is approximately 50%. The responsible pathogen is often not identified in majority of the cases, and even on the prospective studies, only 50%, with available investigations, only 50% of the cases, the responsible pathogen is identified. These are the common list of pathogens which are known to cause community-acquired pneumonia. This could be classified into gram-positive, gram-negative pathogens, atypical pathogens, and viral pathogens. Among these, according to the Western literature, pneumococcus is the leading pathogens. In UK and Europe, it is approximately 50 to 60% of the pneumonias are due to pneumococcus, but this figure is 90% in the pre-antibiotic era. In addition, however, there are a wide range of geographical variations. For example, in China, the Mycoplasma pneumonia is the leading CAP pathogens. Unfortunately for Sri Lanka, we don't have our own microbiological data for community-acquired pneumonia. However, this is a systematic review of the RCTs, of the studies which are performed in community-acquired pneumonia in India and Southeast Asia showed. Pneumococcus is still the leading pathogens, but the percentage is much lesser than the Western countries. It is only 29.2. And then atypical bacterial pathogens like Mycoplasma and Legionella, which stands at 25%. And there is a greater prevalence of gram-negative pathogens compared to the Western countries, where only less than 10% of the pneumonias are due to gram-negative pathogens. In India and Southeast Asia, approximately 22% of the community-acquired pneumonias are due to gram-negative pathogens. And then the Acinetobacter baumannii. Though it is considered a rare pathogen in the Western literature, it is considered to cause approximately 10% of the community-acquired pneumonia in tropical and subtropical countries. So Sri Lanka is a tropical country. The problem with the Acinetobacter baumannii, it is not covered by the conventional antibiotics which is used to treat CAP. Conventional guidelines recommended antibiotics. Moreover, it is often a fulminant infections, and majority of the patients with Acinetobacter baumannii infections are critically require intensive care treatments. And it is important to remember, it is important to not to forget about a Mycobacterium tuberculosis. In Asian studies, 10% of the community-acquired pneumonias are secondary to Mycobacterium tuberculosis. And in fact, the WHO recommend in our countries, all patients with pneumonia should be considered to have a presumptive diagnosis of TB, even if the pneumonia involves the lower lung field. There are a few other pathogens, though they are not very common, but we need to be mindful, Burkholderia pseudomallei, because one reason it needs a prolonged course of antibiotics. The second thing is, it is again not being covered by the conventional antibiotics which is used for the CAP. And we need to use ceftazidime or meropenem to cover the Burkholderia pseudomallei. And scrub typhus, and it is quite prevalent in some, for example, in the eastern part of the Sri Lanka, it is quite more prevalent. And in certain parts of the Sri Lanka, it is more prevalent. Then again, the scrub typhus, which is more prevalent in Jaffna and some other parts of the Sri Lanka, and which is again not being covered by the conventional antibiotics for CAP. Leptospirosis, though it is not a CAP pathogen, it's a CAP mimic. The pulmonary involvement is part of the multisystem involvement with leptospirosis. So we need to consider, especially in a severe pneumonia, we need to think about the possibility of a leptospirosis. So there are several risk stratification tools developed. So one of that is CURB-65 and the Pneumonia Severity Index. These tools are good at predicting the mortality at day 30. Nevertheless, so they can predict the people who are low risk of deaths. Nevertheless, they are not good at predicting the requirement for ICU. For that, there are two other tools. That one is SMART COP and ATS IDSA Severe CAP Criteria 2007. So this is the SMART COP score. There are several parameters which include systolic blood pressure, multilobar involvement, albumin less than 35, respiratory rate, tachycardia, confusions, oxygen requirements, and pH. A score more than 5 is associated with high risk for needing invasive respiratory support or vasopressor support. Similarly, and you have this criteria which is postulated by the ATS IDSA in 2007. There are two major criteria and several minor criteria. The major criteria are the septic shock, which is requiring vasopressor support, and other one is the respiratory failure requiring mechanical ventilations. So one major criteria or three minor criteria is sufficient to make the diagnosis of severe CAP. So there are various laboratory markers which guide our management in pneumonia. The C-reactive protein and the procalcitonin, so these are quite useful markers to differentiate the bacterial and viral pneumonia. A CRP value less than 20 favors a viral pneumonia, and a value more than 100 more favors a bacterial pneumonia. Value in between is inconclusive of bacterial or viral infection. The same way the procalcitonin less than 0.1 favors viral, and value more than 0.25 favors bacterial. Nevertheless, the guidelines doesn't recommend to use these markers alone to make the decision on antibiotics. However, they would guide our decisions on the duration of antibiotics, and especially when we are discontinuing the antibiotics in patients who is making a clinical improvement. So these other laboratory tests like urea electrolytes, creatinines, coagulation profile, albumin, pH, and blood glucose, this helps us to risk stratify these patients and also helps us to guide our supportive management. Radiological imaging in the form of lung ultrasound scan, chest X-ray, high-resolution CTs helps to confirm the diagnosis of pneumonia. So it is mandatory to have a radiological abnormality to say in a patient who is suspected of having a respiratory infection. So this is the difference between the LRT and the pneumonia. If the patient has symptoms to suggest a respiratory infection, and you call it pneumonia if there is a radiological evidence of a pneumonia. If there is no radiological evidence of pneumonia, then you call it as LRTI. Then it also provides clues with regard to the etiology diagnosis. For example, in SARS-CoV virus, there are classic COVID pattern on the chest X-ray, and you have this CORAD score on the imaging. And also, moreover, in the TBs, and some atypical bacterial pathogens and viral pathogens, there are characteristic radiological patterns which provides clues with regard to the etiology. The imaging also helps us on the diagnosis of complications like pneumothorax, pleural effusions, and also the like necrotizing pneumonias due to pentan-valentine leukocidin producing Staph aureus can also be diagnosed with the chest can also be suspected based on the chest radiography. And this also helps on the follow-up. Microbiological testings are not routinely recommended in everybody with pneumonia. So it is recommended in patients with severe CAP. And it's also recommended in patients who are treated with non-conventional CAP antibiotics. For example, if you are empirically covering for MRSA or empirically covering for Pseudomonas or Acinetobacter, in which case you need to perform the microbiological testings. Sputum MCNS is quite sensitive and specific to rule out the infections due to non-core pathogens like Pseudomonas, Staph aureus, and Acinetobacter. However, it is not sensitive to rule out the infections due to the common CAP pathogens like Haemophilus influenza and Pneumococcus, because these organisms are quite fastidious. Having said that in a good quality sputum, if the specimen is interpreted in combination with gram staining, the sensitivity for the pneumococcus would increase. And in studies, it is estimated to be up to 70% if the sample is interpreted sooner rather than later. And again, during pneumococcal and Legionella antigens is not routinely recommended and only indicated in severe pneumonias. And pleural fluid bacterial culture and ABST is recommended in patients with complicated parapneumonic effusion and emphysema. And it is important to remember the moment that we take the samples of the pleural fluid, it needs to be inoculated into the blood culture bottle at the bedsides. Then the diagnostic yield. So the sample of the pleural fluids needs to be sent on the sterile bottle and the blood culture bottles to increase the yield. When you combine the sterile bottle and the blood culture bottles, the diagnostic yield would improve to 50%. And as I mentioned before, the sputum TB studies are mandatory in all patients who present with pneumonia. And then again, the multiplex PCR assays, which are increasingly available in many countries, including Sri Lanka. So this is the BioFire pneumonia panel menu. This has 15 bacterial targets, 3 atypical bacterial targets, and there are 8 viral targets and 5 antimicrobial resistance genes. Though it is not being extensively validated at present, Amita sir believes this is going to be a game changer in the future. This is because of the number of reasons. One thing is that at the point of care, you knew what is the pathogen, and you can identify the non-core pathogens which can cause pneumonias, and you can avoid the adverse consequences of not covering these non-core pathogens with your empirical antibiotic treatment. And it also facilitates your antibiotics stewardships. Moreover, there are a few concerns with regard to the use of this, because there is some, the previous studies have shown there is some discordance between the culture results and this PCR analysis. And it is unclear at present whether this discordance is purely because of the greater sensitivity of these tests, or else whether it reflects the false positivity. This needs to be answered in the future studies. So we'll move to the management of the community-acquired pneumonia based on the existing guidelines. So this is the guidelines, National Antibiotic Guidelines of Sri Lanka, which was published in year 2016, is nearly 8 years back. So for moderate severity pneumonia, our National Antibiotic Guidelines recommends a combination of comoxiclav or second generation cephalosporin plus clarithromycins, or respiratory quinolone like levofloxacin if the patient is penicillin allergic or penicillin or cephalosporin allergics. And in severe community-acquired pneumonia, third generation cephalosporins or respiratory quinolone is recommended. But this is the ATS IDSA guidelines which for hospitalized patients with CAP. This was published in year 2019, where they recommend a third generation cephalosporin in combinations with macrolides or ampicillin, in addition to third generation cephalosporin, they also recommend ampicillin sulbactam in combinations with macrolides. An alternative option is a monotherapy with a respiratory quinolone, which is either levofloxacin or moxifloxacin. So in some cases, non-standard CAP antibiotics are recommended by the guidelines. The first 4 of these are the strong recommendations. These are previous non-MRSA colonizations, previous MRSA infections, and the sputum showing a gram-positive clusters on a good quality sputum, or hospitalization within the last 9 days. There are other relative indications which include the skin and soft tissue infections, history of positive flu test, necrotizing pneumonias or severe pneumonias, end-stage renal failure, intravenous drug abuse, etc. So for these patients with MRSA pneumonia, either vancomycins or linezolid could be used. But if you think it's a PVL producing Staph aureus, the linezolid is preferred over if there is a necrotizing pneumonia, hypotension, leukopenia. In such cases, linezolid is preferred because of its antitoxin effect. The BTS guidelines recommends a combination of linezolid at very high dose in combination with clindamycin, because of both linezolid and clindamycin have antitoxin effects. But clindamycin shouldn't be used as an empirical antibiotics because they cover inadequate MRSA cover. Only 50% of the community-acquired MRSA strains are sensitive to clindamycin. The same way the Pseudomonas, the previous Pseudomonas colonization or previous Pseudomonas infections or sputum showing a gram-negative ROTS or hospitalization within the last 3 months. And there are other indications like bronchiectasis, COPD patients who are, especially those who are with frequent exacerbators, or if they have severe or very severe airflow limitations. So for those patients, those who are suspected of a Pseudomonas pneumonia, a combination of anti-Pseudomonas beta-lactam, an anti-Pseudomonas anti-pneumococcal beta-lactam is recommended. Those are carbapenem, piperacillin, tazobactam, and cefepime. Though the ceftazidime is in the list, its pneumococcus cover is inadequate. So if I am, in my practice, if I am using ceftazidime, I often combine that with a levofloxacin to provide a pneumococcus cover. And then there is, so in combination with anti-pseudomonas quinolone or aminoglycosides. So, and we know from the ANSOP study, which was published several years back, which has shown that antimicrobial resistance to pneumococcus has been extremely high. And particularly for the penicillin, 90% of the isolates were resistant. But this is a new study which was published in Asia Pacific Journal of Tropical Medicine by Dr. Lilani Karananayake and her team. And this has shown for the non-meningeal isolates of pneumococcus, only 13.6% were resistant. So earlier, the ANSOP study included both meningeal and non-meningeal studies. And then recently, that based on the IDSA recommendations, they have revalidated the cutoff for non-meningeal isolates. Now, what they have found is out of the non-meningeal, the respiratory isolates, only 13.6% of the pneumococcus were resistant to penicillin. So this is something quite reassuring. Otherwise, that early days, in my practice, I often combine vancomycin for patients with severe pneumonia to provide cover for a drug-resistant pneumococcus. So if the studies have shown for both meningeal and non-meningeal isolates, linezolid, levofloxacin, and vancomycin shows nearly 100% sensitivity. I think I have to skip few slides. So then again, this macrolide resistance is a huge concern in Sri Lanka. In Asian countries, it is, according to CDC, 90% of the mycoplasma isolates are resistant to macrolides. And when it compared to the Western world, only 10% of the isolates are resistant to macrolides. I think I need to skip these slides. Yes, then again, the supportive management is equally important. And the oxygen therapy as by scale 1 or scale 2 appropriate to the patients. And there is one new evidence, regarding the enhanced respiratory support in pneumonia, the high flow nasal oxygen therapy is considered superior to non-invasive ventilations, especially if they have a higher FiO2 requirement, more than 40%, or if they have increased work of breathing, irrespective of the FiO2 requirement, high flow nasal oxygen therapy is recommended. It has been shown to reduce the requirement for invasive mechanical ventilation, and it has shown to improve the survival. The largest study which recommends this is the FLORELI, which was published in New England Journal of Medicine in 2015. And the other components like management of the sepsis, glycemic control, VT prophylaxis are equally important. So are steroids beneficial in the management of the CAP? To the date, the European Resuscitation Guideline, which was published in 2022, and ATS-ADSA guidelines, which was published in 2019, didn't recommend doesn't routinely recommend treatment with systemic steroids for patients with community-acquired pneumonia, because the results of the meta-analysis which are performed on the patients with pneumonias are conflicting. And though none of the studies have shown the steroid is harmful and the benefit is questionable. So, however, this is a recent study which was published in New England Journal of Medicine in 2023, and this has shown this is where the severe patients with severe CAP were randomized to receive placebo or can I take 30 seconds? So, randomized to receive placebo or hydrocortisone. On the placebo arm, the mortality is almost double than compared to the treatment arm, and these interventions has reduced the need for mechanical ventilations and reduced the risk of developing a shock. And the adverse effect is only the hypoglycemia is more common in the treatment arm compared to the placebo arm. One of my major concerns those days when I was using steroid was whether this increases the nosocomial pneumonia risk. But this study has disproved that this doesn't significantly increase the risk of nosocomial pneumonia. In fact, the effect is neutral. Thank you.
Thank you, Dr. Athavan, for that very informative lecture. The next speaker is Dr. Damit Rodrigo, who is a consultant respiratory physician at DGH Hambantota. He's going to talk on uncommon presentations of rare respiratory infections. Over to you, Damit.
Thank you very much, dear Chairperson, sir, for that introduction. And so the topic that I have been assigned to do in this forum is on uncommon presentations of rare respiratory infections. So I should talk about rare infections, and presentations also must be uncommon. So I thought of getting a case-based approach in this lecture to discuss a few cases that I came across in my clinical practice and the lessons that I have learned, so that you could, I would share it with you also. As the name implies, so, I mean, the rare infections, some infection which is rare in one part of the world may be not rare in another part. And so therefore, yeah, we'll keep in that in mind also. Right, so rare infections usually refers to these uncommon diseases or uncommon infections affecting the respiratory system, often caused by unique pathogens with atypical presentations. And why are they important? They have a public health impact, and there is a diagnostic challenge because the diagnosis is sometimes difficult and treatment is also complex. Talking about public health impact, why it's important is these diseases are infections are very rare. So we healthcare workers, we usually have a very low awareness about these infections, and our degree of suspicion is low. There is a population vulnerability. These rare infections usually occur in the immunocompromised patients, and therefore you have to have a high degree of suspicion of these infections when you are dealing with your immunocompromised patients. And there is a global concern as well to these infections to go pandemic. Sometimes the classic example is the COVID-19, which has gone pandemic. There is a diagnostic challenge. That is one thing I've told you before, because of the lack of awareness again. As healthcare workers, sometimes the awareness about these infections are very low, and therefore the diagnosis can get delayed, or sometimes can be misdiagnosed as something else. There are lack of specific tests sometimes, especially the diagnostic confirmatory tests are lacking to make the confirmatory diagnosis. And also the overlap, the symptoms also are getting overlapped most of the time, because these infections, they share common symptoms. Treatments, when it comes to treatment, they are complex because we have limited treatment options. There are a limited number of researches have been done on rare infections. Therefore, the amount of evidence is very minimum in the literature. So that's a problem. And antimicrobial resistance, most of these rare infections are resistant to most of the antibiotics in the armory. Therefore, we find it difficult in treating these patients. And when treating these patients, therefore, it's very important that we get a multidisciplinary approach. So pulmonologists have to get liaised with the infectious diseases specialists, like the microbiologists, virologists, mycologists, or even pathologists. So I will discuss a few cases that I came across in my practice, so that I can share the lessons that I've learned with you. Recently I got a 61-year-old female who was admitted to the medical casualty with 2 episodes of hemoptysis. She has bled a significant amount of blood within a matter of 24 hours. And she had persistent cough for 3 weeks with fever, loss of appetite, and night sweats also. Denied any chest pain, no shortness of breath or orthopnea. There was no past history of hemoptysis or other bleeding manifestations. She had positive COVID-19 infection 1 year ago, which has gone quite uncomplicated. No history of travel abroad, denied past TB. Only positive history was she was a type 2 diabetic, the control was poor. On examination, she looked ill, and temperature was about 38. Blood pressure was slightly elevated, so as the pulse rate and the respiratory rate. Oxygen sats were 96. On respiratory examination, there was gross deviation of the trachea, and some coarse crepitations were heard with diminished breath sounds in the right lower chest. And this is the chest X-ray, which clearly showed these cavitatory consolidations in right upper zone, and there was evidence of lung collapse in the right side, and trachea being deviated to the right, and diaphragm being pulled up. So what could be the differential diagnosis? What would you think about this presentation when a patient presents like this? Yes, the number one would be pulmonary tuberculosis you should think of. If it is not TB, it can very well be a multilobar pneumonia. We are dealing with a 61-year-old poorly controlled diabetic lady coming with massive hemoptysis with preceding history of fever, cough, and chest X-ray showing these cavitatory consolidations and collapse. This can very well be a lung carcinoma. So these are the common presentations, common differentials that we think of. Or it can very well be a vasculitis, like a granulomatous polyangiitis, or in the old school, vaginous granulomatosis. So these are the laboratory tests. HB was a bit low. Of course, she has bled. ESR and CRP were elevated. Liver functions were within normal limits. Her serum creatinine was high, 2.51, which was not previously known. So in the initial management, we resuscitated the patient. We have transfused about 2 pints of blood in the first day. IV tranexamic acid was started. She was started on broad spectrum empirical antibiotics, initially with IV ceftriaxone and oral clarithrol, and later this was escalated to tazocine or piperacillin tazobactam. But she continued to have her fevers, and her hemoptysis also continued, and so by that time we got her sputum results as sputum AFBs were 3 samples negative. Pyogenic culture was revealing no growth. Gene expert was also negative. We did a MAN2 which again became negative. Ultrasound abdomen showed evidence of chronic liver renal parenchymal changes. So should you consider starting anti-TB treatment in this patient? Of course, my answer was yes, based on her clinical history with fever, cough for three weeks with hemoptysis, and the imaging evidence and high ESR, though her sputum AFB gene experts and MAN2 were negative, I decided to go ahead with anti-TB treatment. I could luckily get a HRCT chest done on this patient. I don't know whether this video would play. Can you play the video? I'm sorry. Play or not? All right, sorry. Okay, thank you. So this is the HRCT chest video. There was evidence of right lower zone cavity with surrounding consolidation, and these are the static images of those. So as a radiologist reported this as consolidation centered on the apical segment of right lower lobe with cavitation and partial attenuation in the right middle lobe, and because of that he has queried whether this is a cavitatory pneumonia, cavitatory consolidation, common differential being pulmonary tuberculosis in our setting, or this could, the second DD was an underlying mass lesion because of the partial attenuation seen in the right middle lobe probably. So I decided to go for a bronchoscopy. This was the bronchoscopic view. As you can see, there was a friable yellow colored mass lesion almost near completely occluding the right intermediate bronchus, roughly around 2 centimeters down the carina. So at this point, the presentation changed. I thought whether this was a malignancy, so I immediately did some bronchial biopsies. The initial biopsies were sent to our pathologist, and they were yielding abundant necrotic tissue. So I thought that I probably have missed the cancer here, so I decided to go for a repeat bronchoscopy. The repeat bronchoscopy also, in that case, the repeat bronchoscopic biopsy was deeply examined by our pathologist, and this is what she has seen. There were broad ribbon-like posiseptate fungal hyphae branching at right angles, and the pathologist was quite certain that this was a case of mucormycosis. So there were no evidence of dysplasia or malignancy, by the way. So this was a case of endobronchial mucormycosis, which presented quite atypically. So this slide I have taken from the internet to show how mucormycosis looked under a microscope, because this can be diagnosed by the pathologist even. You see this branching hyphae, which branched at right angles in mucormycosis, in contrast to some common fungi like aspergillus, where the branching is acute angles, but in mucormycosis the branching is right angles. So this is pathognomonic of mucormycosis. So What would be the next management option? Should we, if she's bleeding, should we go for angioembolization or bronchial artery embolization, or should we refer this patient to a thoracic surgeon quickly to go for a early surgical intervention of debridement or a lobectomy? Should we start an empirical antifungal treatment or just watchfully wait? Yes, what we should be doing is we should start empirical antifungal treatment along with surgical intervention. So she was started on amphotericin, liposomal amphotericin B intravenously, and she was. I have discussed with the thoracic surgeon. I discussed with the thoracic surgeon to transfer her to a thoracic surgical unit, but unfortunately, her condition deteriorated. She bled again, and she succumbed to her illness. So, what would have been the predisposing factors in this patient to develop mucormycosis? She was an uncontrolled diabetic. She had chronic liver and kidney disease, which was not previously known. She was over 60 years, and she had passed a recent COVID-19 infection as well. So all of these causes must have predisposed this patient to develop mucormycosis, and because all these were causing significant immunosuppression. If you can remember, there was a surge of mucormycosis in post-COVID patients, especially in India, which was known as black fungus. Right, so mucormycosis is a life-threatening fungal disease. The two common clinical syndromes are this rhinocerebral and the pulmonary mucormycosis. They have a rapid fatal clinical progression. This disease is, the infection is said to have a very high mortality, about 50 to 70%. And there are 6 clinical groups, mind you, depending on the organs involved. The pulmonary mucormycosis can present with symptoms like fever, cough, dyspnea, chest pain, hemoptysis, especially if the blood vessel is involved, like in the case that in our patient. Radiological picture also can be the consolidations, infiltrations, even nodules, effusions, or cavities. The most important thing is early recognition, because that can decrease the mortality. If you diagnose this early, you can start empirical antifungals and go for radical surgery. So the lessons that I learned from this case: early histopathological diagnosis is important in preventing fatal outcomes in pulmonary mucormycosis. An early combination of antifungal treatment along with surgical debridement is important in invasive mucormycosis like this, because there's a significant amount of vascular thrombosis that happens and a tissue necrosis, which prevents diffusion of antifungals, and this is the reason that you have to go for early surgical debridement. Discuss this another case quickly. A 62-year-old female, I recently encountered. She had productive cough, intermittent hemoptysis, and low-grade fever for about 3 months with loss of appetite and loss of weight. When she was presented to me, her weight was about 36. She was grossly cachectic. There was a history of bronchial asthma. On examination, other than cachexia, there was nothing remarkable. Initial investigations, ESR was very high, sputum FBs were negative, sputum PCR for TB again negative, MAN2 was slightly positive, about 11 millimeters. Chest X-ray was showing a right upper zone cavity with a small consolidation there. Again, this patient, because of her clinical symptoms and the radiological evidence, I decided to start her on anti-TB treatment. And after about 3 months, chest X-ray was repeated. There was no very poor radiological resolution, and therefore I decided to go for a CT chest. And that CT chest, our radiologist has noted the right upper lobe posterior segment hyperdensity, and he was querying whether this was a mucus plug or a foreign body, and he has asked me to go for a bronchoscopy. Luckily, I could record the bronchoscopic video of this patient, which I play here. So this was the bronchoscopic view. You can see there was a large endobronchial mass sitting on, completely occluding the right upper lobe bronchus. Again, this presentation, when I saw this, my first diagnosis was a malignancy. So I did some bronchial biopsies again, and again, a pathologist examined the deep sections in this biopsy, and she came up with a diagnosis of actinomycosis in this case. There was no evidence of dysplasia or malignancy. There was colonies of actinomycosis surrounded by neutrophils. So this was a case of pulmonary actinomycosis or endobronchial actinomycosis, which is very rare. Again, presented with as something else. Initially, I thought it as a simple, pure and simple tuberculosis, and again, I saw an endobronchial mass. My diagnosis changed to a malignancy, and then finally it became a case of actinomycosis. By the time I got her down and did a bronchoscopy, I have completed about more than 4 months of anti-TB treatment, and she has clinically responded. So I decided to continue her anti-TB treatment anyway, and she was started on antibiotics, coamoxiclav and oral clindamycin as advised by my microbiologist. And at the end of her anti-TB treatment, I got her down and did the bronchoscopy again, but this endobronchial mass was still lying there. So now I have referred her to a thoracic surgeon for a debridement. So actinomycosis is a gram-positive non-spore-forming organism. Characterized by obligate or facultative anaerobic rods. There is a cervicofacial and abdominal and pelvic and thoracic infections, but the endobronchial actinomycosis is extremely rare. Endobronchial actinomycosis can be misdiagnosed as malignancy, so unresolving pneumonia, like in my case, and it should be, endobronchial actinomycosis should be included in the list of differential diagnosis of any endobronchial mass when it presents like this, even down in your list. So this was the second case. There was this is another case of, this case was a nocardiosis. This why I put this, included this here is, because nocardiosis, it's a weakly acid-fast bacilli. Even in acid-fast stains, you can see these fine filamentous organisms with weakly acid, acid-fast in the acid-fast stain, positive. And they are slowly growing on LJ media as well. There is a specific LJ medium which grows it fast, but can grow on normal LJ medium very slowly. So nocardiosis is again a rare infection. There are a lot other rare infections that can present on an atypical manner, which I have listed out here. This was a case of pulmonary histoplasmosis, which was recently presented to Candy, Professor Madhagadha Research Unit. Looked like a miliary tuberculosis, initially treated as a miliary tuberculosis and later found to be histoplasmosis. Blastomycosis can initially present as metastasis like this, but can be later changed to blastomycosis. Coccidioidomycosis, I had a case some time back. Unfortunately, I couldn't retrieve that case of a patient who was returned from Middle East, quite common in the Gulf area. This can present as an interstitial lung disease with reticular shadows in X-rays and even in CTs. Pneumocystis pneumonia, not very rare, but you have to have a high suspicion in your immunocompromised patients. Like HIV/AIDS, these are all fungal, mind you. Melioidosis, not very uncommon. Now we had a surge of melioidosis cases in the last decade. Non-TM infections, again, there are a lot of rare non-TM infections we encounter. Unfortunately, there's a problem of speciating them. Atypical pneumonias, again, Legionella, Mycoplasma, we commonly, not very commonly we encounter these days sometimes. This is a case of a Mycoplasma with upper lobe consolidation with the bulging fissure. Viral pneumonias, varicella, HSV, cytomegalo, adeno, they all are rare viral infections that can present in atypical manners. So why important? Why they are important, why recognizing them is important is there's very limited awareness among healthcare workers, and these infections are also have a very low prevalence. Diagnosis can be delayed. We probably be thinking of something else, and therefore they can be delayed, or sometimes we probably misdiagnose them. And there's increased severity of disease severity in these infections, and there are a lot of complications, and therefore the timely treatment is important. Thank you. Thanks.
Thank you very much, Dr. Damit Rodrigo, for that very interesting presentation with a lot of interesting cases, rare presentations, but very interesting. Now we invite Dr. Bandhu Gunasena, Senior Consultant Respiratory Physician, for the next lecture on current management of drug-resistant TB. Over to you, Dr. Gunasena.
Thank you, Damika. Since this is a vast topic, I will try to rush through because I think within 20 minutes may be a little difficult for me to complete this, but I'll try my best to do the justice to you all. These are the two documents I have selected, the 2019 ATS, ERS ATS guideline, and then the revision of the WHO guideline in 2022. You know how this drug resistance is created when you partially treat the organism, the colonies, then you get the resistant fellow getting selected out and causing total colony being resistant to your anti-TB drugs. Eastern European bloc is, and the old Soviet Union has the highest incidence of multi-drug resistant tuberculosis. XDR-TB, or extensively drug-resistant TB, was reported worldwide. Even Sri Lanka, we have 1 or 2 cases, though in this map it's not shown. If you talk about resistance, we have monoresistance, as you all know, it's resistance against only one drug, and polyresistance is more than one drug other than isoniazid rifampicin together. MDR-TB is by definition resistance against isoniazid and rifampicin. And if you see the word RR somewhere, that we are referring to rifampicin resistance, or if you see HR somewhere, you are referring to isoniazid resistance. Pre-XDR TB is where you have resistance against isoniazid rifampicin and fluoroquinolones. And if that organism is further resistant to group A second-line anti-TB drug, namely either bedaquiline or linezolid, you call it XDR-TB. I will go into details of this thing in due course. Now, the diagnosis was revolutionized by molecular diagnostic techniques, where we rapidly diagnose MTB infection and drug resistance with our expert MTB-RIF, or we call it gene expert, which has a sensitivity of about 130 colonies per ml to give a positive result. But if you do ultra, MTB-RIF ultra, what is done to now in Sri Lanka, it has high sensitivity of about 16 colony forming units giving a positive result. And other than that, we have line probe assay, where for first line drugs we have isoniazid and rifampicin resistance can be detected. Second line probe assay can be done to detect quinolone resistance and injectable aminoglycoside resistance. If you see the isoniazid and rifampicin resistance in a culture medium, you will know that this is a MDR-TB case. The whole genome of the TB bacillus has been worked out. Now, depending on different genes and gene mutations in this genome, you will recognize the resistant organisms. Isoniazid is detected by CAT-G mutation or INHA mutation. And one other important thing is RPOB gene, which is detected in the gene expert machine. And also this gyrase A and gyrase B indicative of quinolone resistance, which are more important at the moment for us. We have expert, and there are other techniques like TrueNet, which is more sensitive but not less specific compared to gene expert. Now, currently in Sri Lanka, we are using gene expert and expert MTB-RIF ultra and line probe assay. And we are doing expert XDR, where we can detect some more antibiotics like isoniazid and fluoroquinolone, and same time amikacin and ethianamide. But with this economic crisis, the laboratories are facing problems. The development of National TB Reference Laboratory the capacity building is important to do proper management of MDR-TB. Line probe assay, currently we are doing isoniazid resistance and rifampicin, but it can be extended to aminoglycoside bedaquiline, one of the main drugs in our armamentarium against MDR-TB, and linezolid, clofazimine, and delaminine. And expert XDR can detect, more importantly, isoniazid and fluoroquinolone, but amikacin also in some occasions we have to use aminoglycoside in these patients, and ethanamide. This gyrase A and gyrase B in quinolone resistance, once it's there, some of the mutations can be treated with high-dose moxifloxacin, whereas some of the gyrase A mutations are resistant to even high dose of moxifloxacin. Now, these because of these small facets and various detailed description of resistant patterns are needed, WHO now recommend whole genome sequencing or next generation sequencing to diagnose the resistance. Currently, it's not available in our country. I think we will be getting these things in future. If our economic situation improves, I think this is the next step in our management of MDR-TB patients. You will often see a thing called expert MTB ultra trace call with RR indeterminate. That is because the genome, part of the genome is caught in the test, but your RPOB gene may be somewhere else, and the machine did not detect it. It indicates that you are not sure whether it's a MDR, RR, rifampicin resistant organism or not. In that case, you will be treating the patient as drug-sensitive TB, but you will await the culture results, either line probe assay or DST. But no, there's no point. It's not recommended by the WHO to repeat the gene expert ultra all the time until you get RR result. And on treatment, we have, now we can't use isoniazid and rifampicin in these patients. You may be able to use ethambutol pyrazinamide and along with your other second-line drugs. We were using, earlier we were using long regime of 24 months treatment. Initially for 6 months we were using kanamycin and rest of the drugs. We had levofloxacin or quinolones at that time also. But later on in 2016, WHO, after Bangladesh studies, they recommended a short regime of 9 to 11 months, considering improved compliance, where we were using 3 first-line drugs and another second-line drugs with an injectable aminoglycoside. The second phase of the treatment, continuous phase, we did not have ethanamide or amikacin. ATS-CRS guideline in 2019 was somewhat against this recommendation of short regime. And they still believe that the treatment should be more than 6 months after culture conversion of intensive phase and at least 21 months of full treatment, and XDR-TB also extended treatment. But that time we were using injectable aminoglycosides, and they were quoting the STREAM study, and they were saying that if the more effective oral anti-TB drugs are available, this recommendation will be reviewed again to think of a short regime. Then WHO did this evaluation analysis of the individual drugs and oral drugs, new oral drugs, and bedaquiline came number 1 as a strong recommendation for second-line drug for anti-TB treatment. And then fluoroquinolones and linezolid came higher up. Then ethanamide has a conditional recommendation against the use of ethanamide and injectable aminoglycoside, and azithromycin, clarithromycin, and clavulanic acids there's a strong recommendation against. And also about using so many drugs, then they have classified according to the efficacy of these drugs. Group A is quinolones plus bedaquiline linezolid. Group B had clofazimine, cycloserine, and the rest of the drug below that. And the problem came, how many drugs for how long? And we were using multiple drugs, 5, 6, 7 drugs. And then these studies have shown that in the intensive phase, about 4 drugs. And if you go beyond 4 drugs, the benefits are not so dramatic. And again, continuation phase, they were limiting to 3 drugs. And beyond, if you go on increasing, the benefit was not so much. And WHO went into so many studies, trials, and finally there's a BPAL study showed 4-drug or 3-drug treatment against quinolone-resistant organisms have shown results. So many studies they have reviewed, and then out of that, 3 were selected more with hard evidence: TB practical, scenic study, and XT trial. And it has shown, next TB trial was about bedaquiline, pretaminid, and linezolid for 6 to 9 months of treatment compared to a standard previous treatments. And then Scenics was discussing about the linezolid dose. And TB practical study was a study using bedaquiline, pretaminid, and linezolid plus moxifloxacin in MDR-TB patients in contrast to the standard previous regimes, 24 months regime. With all that evidence, WHO now recommends bedaquiline, pretaminid, linezolid, and moxifloxacin regime for MDR-TB. And in case if you detect quinolone resistance, you go for only 6 to 9 months of bedaquiline, pretaminid, and linezolid regime. 9 months if the culture conversion or for delayed converters. And next trial was a study where they used oral drugs in a shorter regime compared with previous longer regimes. And then it has shown good results. Therefore, they still recommend the shorter regime without amikacin. Instead, we are using a more powerful drug, bedaquiline. And the same old 3 first-line drugs and the other second-line drugs. Now, so this is that. In pregnancy, of course, you don't want to give ethanamide for a long time, so long period. Therefore, they recommend a shorter period of linezolid in the same regime. When you start shorter regime, there are a few things. If you are going to give go 1 year long extended period of treatment in extensive parenchymal disease or extrapulmonary TB like TB meningitis, the short regime is not recommended. And also it's important that we know that the patient is sensitive to quinolones. And other than that, isoniazid sensitivity is important because you are using high dose of INH. And so shorter regime is for milder forms of the disease with good evidence of fluoroquinol sensitivity, and patient were not exposed to previously to second-line drugs. And then if the patients are not eligible for short regime, you are going for either BPAL-M or your standard regime, longer regime, which is decided by giving at least 4 drugs in the intensive phase. If you can get 3 drugs from group A and 1 from group B is the ideal, but if you don't have that, you may get drugs from group C. In that case, you may have to increase your number of drugs to 5 or even sometimes 6. Depending on your requirement, you might extend the period of bedaquiline from 6 months to a further period. Now, this is the standard 18 months regime, longer regime that, as I told you earlier, depending on the patient's requirement and the facets in the management, you might change the drugs. You might extend the drugs, so you might withdraw certain drugs because the linezolid can cause side effects towards the end of treatment. Then, in that case, you may have to withdraw linezolid and add something else. This is for isoniazid resistant patients. If the patient has single drug isoniazid resistance, the recommendation is to use rifampicin, pyrazinamide, ethambutol, and levofloxacin for 6 months. Because our combination tablet contains isoniazid, generally the recommendation is to use the fixed dose combination HREZ plus levofloxacin for 6 months. And if the patient has pre-XDR, that is, if you detect quinolone resistance by your expert XDR or culture, from the beginning, you will use only BPAL regime without moxifloxacin. And if the patient has, this is the standard regime that I told you. but you can, if you cannot use one drug, then you might add on cycloserine or ethanamide, depending your problem. And in case of children, bedaquiline is not recommended. In that case, the regime will be bedaquiline will be replaced by cycloserine. And if the quinolone resistance is there, pyrazinamide and ethanamide is added to the regime. And 3 to 5 year children, again, still 3 to 5 year people, still you can, you don't give bedaquiline, but you can give cycloserine. But if there's quinolone resistance, then delamanid, cycloserine and ethanamide combination is used. In pregnancy, linezolid is not considered as a good treatment. They are cycloserine and pyrazinamide is added to the regime. And cure is if you have more than if you have more than 2 cultures positive consecutively in the intensive phase or continuous phase, you consider it as a cure. And if one culture becomes positive, then you have to wait for another 2 months, 2 consecutive cultures to become negative for you to call it a cure. A treatment failure if the culture is positive at intensive phase, end of intensive phase, so if the culture reverses in continuation phase, or if the treatment is stopped due to side effects, that is treatment failure of MDR-TB. I rushed fast and I think I have extra 3 minutes left, so I will come to some small few points which I would like to talk because I am leaving this profession and you are taking over. Why we are so worried about WHO is the WHO, World Bank and the Green Light Committee is the funding agency. They are still funding our MDR-TB management. When we adhere to our guidelines, the Green Light Committee will come and review whether we adhere to our guidelines. We write guidelines with, in concurrence with the WHO experts who come here and give their specifications, and we will write a practical approach to TB management. And the Green Light Committee will review, see whether we adhere to the guideline. And if you have so much deviations, they will not give green light to the World Bank. World Bank is the one which will send the money to the Global Drug Facility to deliver the drugs and other equipment to us. So shipments and consignments will not come to us if the World Bank will not pay the checks. Now we will, the campaign and the Stop TB partnership of WHO will work parallel to do the right, work according to the WHO guidelines and get the funding for to run the program. So we have, for the future, we have a very positive approach or negative approach or neutral approach. I think this would be the best approach. She's cautious, she's watching forward whether we are going to do the right thing. So you may have so many shortcomings. Your laboratory may not function at one time. Your drug supply may, even at present, we have a problem. So you have to sharpen your skills and making clinical decisions and actively participate in guideline development. Because if you don't participate in guideline development, you will get a guideline which is not practical. Then finally, we'll end up in a deadlock. And you recognize strengths and weakness of each other, the campaign, and respect other healthcare workers, maybe an ambulance driver, maybe the sanitary laborer. These guys are intelligent fellows. Sometimes they are very helpful. They will get understand the task and adhere to guidelines and teamwork at national and international levels. That will see through you to this dangerous cliff ahead. If you are consciously approach this, you will avoid the disaster. Thank you.
Thank you, sir, for that very interesting and very important lecture on MDR-TB. The final speaker for the symposium is Dr. Amita Fernando, who's the consultant respiratory physician at NHSL. Amita sir is going to speak us on paradoxical reactions in tuberculosis. Over to you, sir.
Good morning to everyone, and thank you for that kind introduction. And I thank the council and the academic chair for inviting me to speak on this topic. This is the outline of my talk. It will begin with a illustrative case. This is a 24-year-old male who was taking treatment from I think he came from Kurunegala. He had a contact history of TB. His father had TB. Gene expert was positive, but rifampicin sensitive. He also had complaint of headaches. At that time, a non-contrast CT chest was done, which was normal. He mainly had pericardial effusion. The pericardial fluid ADA, adenosine deaminase, was 40. Pericardial fluid PCR became positive. Gene expert, that is the gene expert, it was a rifampicin sensitive strain. He had a ESR of 79 at that time, and his MAN2 was positive at 15 millimeters. He was started on a fixed dose formulations. Rifampicin was withheld at one point in time because there was concerns about thrombocytopenia. He was also started on prednisolone as was appropriate for pericardial TB. Then later on he presented to the National Hospital with headache, worsening headache. He was switched to individual drugs from fixed dose formulations because we have had many discussions on this matter, and we see that we have no real evidence to see how fixed dose formulations cover the cross the blood CSF barrier, and also we do not in the fixed dose formulations the rifampicin dose is a little lower. So in CNS TB we like to have a little high rifampicin dose of about 15 milligram per kilogram body weight to reach adequate CSF levels. So the patient was switched on to individual drugs. Patient had a CT scan, an MRI scan which showed tuberculomas. Then again in September, patient was reviewed 2 months later while on anti-TB treatment and dexamethasone or prednisolone, I think it was. And then the patient had a relapse, and the patient was treated with again with steroids for a presumed paradoxical reaction because of the tuberculomas. She went on to have several reviews and several MRI scans which showed very resistant tuberculomas, especially in the optichiasmal region, and a systemic inflammation as evidenced by raised ESR and CRPs. After multidisciplinary discussion with the neuroradiologist, the neurologist, and then ourselves, we decided to treat this patient as for paradoxical reactions with steroid resistant tuberculomas. The patient went on to have, this is mind you a non-HIV, HIV negative patient. He has had HIV testing done on several occasions, and he's on a sensitive strain. So after MDT discussion, we started cautiously on thalidomide, initially at 50 milligrams daily, then when we increased the thalidomide. So here you see serial CSF examinations. Some you'll note that when the patient had worsening lesions, neurological signs, some you'll note that there is a slight neutrophil preponderance in some of these CSFs. Sugar has been low in some, and we had a few reports where ADA was done. ADA also, there is not really strong evidence of using adenosine deaminase in CSF to diagnose CNS TB. Because there is no gold standard to compare it, and also there is no cutoff levels. We have tend to use about 10 as a cutoff level, but this is not, some neurologists prefer to do this because we don't have real good markers for CSF in the CSF for TB, because mostly we have diagnostic challenges because the volumes of CSF that we send in these patients are less than 2 ml. And at these concentrations, our positivity rate is not what is described in the literature for Gene Expert and Gene Expert Ultra. And centrifuging CSF samples, I think Dr. Dhammika and us, we have had many discussions on this. It is not uniformly practiced in many laboratories. So our Gene Expert and Gene Expert Ultra results have not been on par with what is described in the international literature. So a patient, this is one such patient, but we have many patients like that which are difficult to treat, which we manage jointly with the neurologist. We have at least 1 or 2 MDTs once in 2 weeks at least when we encounter these patients. So these are serial MRI scans of these patients. showing some showing a reappearance of tuberculoma, a lot of edema, diffusion weighted films. The neuroradiologist says that shows evidence of edema, and some have shown resolution at one point in time here in June. But again, despite all of this treatment, patient has developed all this. This patient went on to have a brain biopsy, and the histology was suggestive of TB with caseation, and also the stains and gene expert was not positive in this, but unfortunately cultures were not sent. So in summary, this is a summary of this patient. I'll move on to my next slide in quick. So paradoxical reactions can occur in patients who are non-HIV positive and HIV positive. Mainly we see paradoxical reaction in non-HIV positive patients related to lymph node TB, but it's also it can happen in HIV positive patients. A paradoxical reaction is described as a clinical and or radiological worsening of a patient who is on treatment for bacteriologically confirmed or very likely diagnosis of tuberculosis based on the radiology and clinical and biochemical parameters. Clinical and radiological worsening can be of pre-existing lesions, or new lesions can appear, as you know, especially in lymph node TB. It's a diagnosis of exclusion. In our differential diagnosis, when we have these MDTs, we take into consideration poor compliance, drug resistance. We had no evidence in our patient because the gene experts were positive. Cultures were never gave any organisms. Alternative diagnosis like toxoplasmosis in immunocompromised patient, cryptococcosis, and other non-infective etiologies. So these have to be excluded, and abscess formation is one of the things that we also consider. So inflammatory response associated with rapid resolution of or reconstitution of immunity in a previously immunocompromised patients. Most of these information come from HIV positive population, and the patient has to be on anti-TB drugs for at least 10 days. And usually these are described in 30 to 90 days after starting treatment. But we have seen many patients, sometimes post-treatment also, especially in relation to lymph node TB, where patients develop presumed paradoxical reactions and clinical manifestations even after we have stopped treatment. So these post-treatment paradoxical reactions also are described. It is often self-limiting, but can also cause significant morbidity and death. The incidence varies according to the patient population and site of lesion, as we know, lymph node and CNS TB. It's more common in HIV co-infected, where it can be about 15 to 57%, and then it's termed TB iris, or immune reconstitution inflammatory syndrome. In non-infected HIV-infected patients, it's commoner with extrapulmonary TB, as we know, in lymph node and CNS TB, the commonest extrapulmonary sites. The incidence varies in non-HIV positives between 2.5 to 23%. Morbidity is around 11 to 36%. So there's this other entity that has been described in relation to HIV, unmasking TB iris. In this case, a subclinical tuberculosis infection manifests after starting anti-TB treatment. This is observed in about 1 to 4% of patients whom antiretroviral treatment has been commenced. It is not only true for TB, but other infections also that occur in the immunocompromised can manifest. Opportunistic organisms can manifest and give during this unmasking when immune reconstitution happens. So the international network for study of HIV-associated iris, most of the literature comes in relation to HIV patients, as described major criteria and major symptoms and minor symptoms in diagnosing paradoxical reactions and TB iris. So new lymph node enlargements, cold abscesses can happen due to paradoxical reactions. Focal tissue involvement can happen. Sinus formation can happen. New or worsening radiological features of TB. New or worsening CNS TB or new or worsening serositis. We have seen patients, pleural effusions occurring in patients who are on anti-TB treatment for TB lymphadenitis. So we have assumed that these are a more disseminated form of tuberculosis, but in fact this may be a paradoxical reaction. So we have extended treatment in such patients for 9 months, 10 months. Now looking back on this data, some of these may be paradoxical reactions, and whether we are justified in extending treatments, we have to have a rethink. So for new or minor symptoms, new or worsening constitution symptom, new or worsening respiratory symptoms, new or worsening abdominal pain, serositis, hepatomegaly, splenomegaly, abdominal lymphadenopathy can occur. So risk factors are high bacillary loads at the outset of treatment. Certain MTB strains and lineages have been associated with. There are about 9 lineages. And urine lipoalbumin, which we have been pushing for the from the WHO to get specially as a diagnostic utility in HIV patients. This LAM10 lineage has been associated more with more virulence and paradoxical reactions. So disseminated disease, ethnicity, some ethnicities may be predisposed to this, and there may be a pro-inflammatory phenotype among these patients. So extrapulmonary disease, lymphopenia, prior to starting anti-TB treatment are some of the described factors. So I will go on, I'll move on. So features of systemic inflammation with fever, tachycardia, night sweat, weight loss, pulmonary involvement occurs in about 39%, protracted lymph node enlargement, usually cervical nodes, cold abscess, sinus formation, all of these can happen. So CNS involvement we discussed, and there can be even liver involvement, and your liver transaminases can increase. You can get cholestasis due to paradoxical reactions also. So differentiating this from drug-induced hepatitis can be challenging. So major sites of involvement of TB iris, most of this data again, as I said, coming from HIV populations, lymphadenitis, pulmonary involvement, CNS involvement, and as I have described many of these. So you will have a differential diagnosis when you are looking at these patients, especially in the HIV populations where malignancies like Kaposi's, lymphoma, other infections like cryptococcal, toxoplasma, coccidioidomycosis will come into play. So CNS TB iris, 12% with paradoxical paradoxical TB iris have CNS involvement. CNS TB iris is common in up to 50% with TB meningitis. So extra conditions outside the CNS also can give rise to paradoxical CNS involvement. There need not be CNS involvement bacteriologically. Patient occurs in patient with or without CNS TB prior to starting antiretroviral treatment. CNS TB iris carries a mortality of around 13 to 30%. So as I said, high viral loads, low lymphopenia, and LAM positivity in urine, high CSF, TNF alpha, and low interferon gamma levels are some of the risk factors that have been proposed. So features of CNS TB iris, meningitis, intracranial tuberculomas, brain abscesses. When we had our MTD discussions on patients, brain abscesses we thought could be due to TB itself. And we have had discussions with the neuroradiologist who says that when there's in the diffusion weighted films, when there's suggestion of edema, it could be active disease. And some patients we have referred the neurosurgeons for biopsies. So new onset seizures, cranial nerve palsies. So there can be varied CNS manifestations. So prevention of CNS TB iris, to recognize these predisposing factors that I mentioned earlier and see whether these patients, these are mostly again in patients with retroviral disease who these risk factors have been identified. So WHO recommendations on starting antiretroviral anti-ART treatment with a patient with diagnosed TB are as follows. So sometimes even if the CD4 counts are not very low, still there is a risk of developing paradoxical reactions. Of concern is tuberculomas, which can behave like space occupying lesion and can cause significant morbidity and mortality, and unmasking of cryptococcal infections, where cryptococcosis can predispose to this. So prednisolone has been widely used as immune modulating agent in these patients. So the duration of steroids, as we have been used in clinical practice, we opt for dexamethasone, and we, after having discussions on the extrapulmonary TB guideline, we follow the Indian guideline as to the dose of dexamethasone in CNS TB. There are anecdotal reports of benefit from TNF alpha inhibitors, infliximab, in patients refractory to corticosteroids, adalimumab, thalidomide in patients with resistant tuberculomas and steroid-dependent patients. IL-6 blockers like tocilizumab may also have a place, but these are all again anecdotal cases, case series. There is no real randomized controlled trial evidence on the use of these drugs. So again, an NSAIDs and aspirin, aspirin I thought because of vasculitis, that some of these patients with CNS TB are thrombogenic and vasculitis can occur, so because of that. So, and other drugs have been also used, and these VGF inhibitors have also been used. Interesting things are there about montelukast, where montelukast has anti-inflammatory properties and has been recommended as an anti-inflammatory agent. So we are all familiar with paradoxical TB lymphadenitis, patients coming with cold abscesses, caseating nodes, and the histology becoming positive, FNAs become positive. We never culture anything in these organisms. Gene expert may be positive, as you know. Non-viable bacteria can give rise to gene expert positivity. We have treated them as for secondary infections with antibiotics, given steroids, but there is no real evidence to support steroids, and most of these patients with large lymph node more than 3 centimeters will require surgical referral. So extending treatment again in these patients and giving steroids, even the Indian guidelines, surprisingly I didn't see any evidence in the Indian guidelines about giving steroids in lymph node for TB, paradoxical reactions in lymph node TB. Again, the utility of these TNF alpha blocking drugs, we may have to discuss and see whether they will have a place in paradoxical lymph node TB. Again, pulmonary manifestation can happen. As I said, pleural effusions can occur, and then during the course of treatment, which may be a paradoxical reaction. Segmental collapse due to endobronchial lesions, tuberculomas, like lesions in the bronchial tree can also happen. You have to be mindful of co-infection with aspergillus, which we have seen on occasion where the TB and aspergillus co-infections are there. So, so these are features of some of TB iris in abdominal involvement. So this is like a illustration of pathophysiology of TB or paradoxical reactions in tuberculosis, where there are predisposing factors, as we described earlier, and there is an immune reconstitution or a hyperimmune state to the bacilli being killed and the immune system being exposed to a surge of antigenic material. So I'm not going to discuss the pathophysiology because that's not a strong area of mine, but the idea is to look at some of the potential biomarkers for these diseases, for these things, to have confidence in our clinical diagnosis where there could be biomarkers in blood signifying systemic inflammation or some biomarkers in the CSF. So there are potential candidates like IL-6, IL-18, IP-10, IL-33, TB-specific interferon gamma, and other markers which have been described in literature, mostly in relation to in HIV patients with paradoxical TB iris. Again, there may be a particular phenotype who is predisposed to this hyperimmune state. There are single nucleotide polymorphism in some patients, and this leukotriene A4 hydrolase patients who have this thought to be steroid resistant, and there may be a steroid resistant phenotype. We have often thought about this because when we start our patients for CNS TB in particular, who are not in non-HIV patients, anyway we start them on steroids. Anyway they will get dexamethasone or prednisolone for a period of 4 to 6 weeks. Still there are some patients who go on to develop tuberculomas. Again, when we treat these tuberculomas as paradoxical reactions, in the first place, it's very difficult to come to a conclusion whether these are paradoxical reactions. And when we treat also, there is no consensus on how long the steroids should be given. We had one patient whom we gave infliximab. So again, some issues to ponder. This is a clinical challenge where we encounter these patients, mostly at the NHSL where I'm working. So we get a lot of referrals to this to a tertiary referral center. We have to deal with these patients who are sometimes on anti-TB medications, sometimes presuming that there may be resistance. We have also gone on to second-line drugs like linezolid, ethermide, quinolones in these patients. Some patients have been on treatment for more than 2 years, and similar problems are encountered in spinal TB also. And the histology has been unhelpful, where we get caseation, but we haven't, in spite of giving all this thalidomide and things, we haven't seen mycobacteremia, or we haven't seen any worsening due to worsening of TB in these patients. So the interesting thoughts and challenging cases where we need a good biomarker for paradoxical reactions, and we need to identify certain phenotypes who may be predisposed to this hyperimmune reaction developing tuberculomas. So in conclusion, TB iris in all forms can cause significant morbidity and mortality. HIV-TB co-infection is a significant risk factor. It's a diagnosis of exclusion, as we saw. Many other things like poor compliance, drug resistant, known complications of diseases, especially in CNS-TB, abscess formation. But again, abscess formation can happen in paradoxical reaction also. So there is no single measurable biomarker that exists at present. There are potential candidates, but no. So, and looking at gene polymorphism, and looking at a particular hyperimmune phenotype or steroid-resistant phenotype may provide some answers why some of our patients are behaving like this. So new drugs are in the pipeline. Thalidomide, we have, as I have mentioned, which has been used mostly in South Africa. IL-6 inhibitors, tocilizumab are other potential candidates. Thank you.
Thank you very much, Dr. Amita Fernando, for that very interesting lecture on paradoxical reactions, which may cause quite a big distress to the clinicians. So now I think we have 1 or 2 minutes for a few questions from the speakers. We have 4 speakers. Any questions from them?
Good morning. I have a question for the first speaker regarding the use of the BioFire panel, which is a PCR for respiratory pathogens. So my question is, it is a genetic testing, so how long after infection does it remain positive? Is there a way of identifying that? For example, if a patient has been treated and cured, can it remain false positive even after infection? And will that kind of confuse our efforts if there's a new infection? Thank you.
So this question remains to be answered on the future studies. So there has been concerns with regard to the false positivity, whether the genetic positivity and the culture negativity is actually because of the. So there is already, the studies have shown there is so much of discordance between the culture results and the genetic studies. And whether this is as in TB, we know that because gene expert could be positive because of the dead bacillus in a previously treated patient, it can be positive up to 1 year. So this question needs to be answered on the future studies.
Another question or 2 can be allowed, I think. Any more questions? Yes.
My question is to Dr. Adhavan. Thank you for a very interesting presentation and giving us some points to ponder. I was interested about his Acinetobacter, community-acquired Acinetobacter infections. I was asking him what is the antibiotic sensitivity pattern of these Acinetobacter isolates that we presumed are community-acquired, and how we would deal with the community-acquired Acinetobacter infection.
Yeah, so the community-acquired isolates are often intrinsically resistant to the 3rd generation cephalosporin. And some studies have shown that they have intermediate sensitivity like ceftriaxone and cefotaxime. So they are not covered by the conventional antibiotics, but it is often sensitive to the aminoglycosides, the extended spectrum beta-lactam like piperacillin, tazobactam, carbapenems, and even ceftazidime. And it is also covered by the doxycycline. But in Acinetobacter cap, the guidelines suggest to use either carbapenem in combination with aminoglycosides because they are rapidly fatal. They want an antibiotics with a very high bactericidal effect. So they prefer, even though the other antibiotics, the inferior antibiotics are sensitive, they recommend carbapenem plus or minus aminoglycoside as an empirical antibiotics, if you suspect or if it is positive on the BioFire PCR.
Any more questions? Think. Yes, another. Yeah, one last question. Yeah.
Actually, just a last suggestion for the second speaker, where a cause of the pneumonia was identified to be Aspergillus infection. So can I suggest that for any patient who presents with respiratory tract infection suggestive of infection for more than 2 or 3 weeks, should we consider routine fungal culture in these cases? Because in most cases, they do turn out to be due to fungus.
Actually, the case was mucormycosis, not an Aspergillus. So for mucormycosis, the diagnosis in that case actually came from the biopsy specimen histology. The microbiological diagnosis, I think it usually should come with the fungal cultures. There are specific culture media to grow that, like the potato dextrose media or something which we lack here. So it's basically from the histological diagnosis that we came, I think, yeah. This is for the Aspergillus you asked, yeah. For Aspergillus, we usually go by galactomannan here because it's quite, we get it quite fast other than going for a fungal culture. Yeah, thank you.
If you do it on a BAL, that will be better.
Yeah, BAL galactomannan would be more diagnostic in that case, which is not available, unfortunately, in the government sector here. Quite expensive in the private sector.
It's available at MRI.
Sorry, madam, I didn't know that.
Right. Go on.
Thank you once again for the 4 speakers for that for those excellent lectures, and also for keeping to the time, and also for the participant for that lively engagement. So to conclude the symposium, may I kindly invite the 4 speakers to come forward for the tokens of appreciations and for the certificates. Can I invite Dr. Madhavan to the stage? Dr. Damit Rodrigo. Dr. Bandhu Gunasen. Thank you.
Next up, I invite the Academic Chair of the SLCP, Professor Dushantha Madagedra, to present the tokens of appreciation to the chairpersons. Thank you. Ladies and gentlemen, we cordially invite you to enjoy the tea, which will now be served outside. The next session will be starting at 11:30 a.m. sharp.